Welcome back to the Deep Dive. I hope you are ready to settle in because today we are doing something a little different, a little special.
It feels special. We've got quite the eclectic mix of sources today. Immunology papers, clinical guides, and I think I even saw some notes on reptile biology.
You did, but there is, as always, a method to the madness.
I'm sure there is.
Today, we are turning the clock back. We are time traveling to the year 2006. So I want you, our listener, to just imagine this for a second. You're a tired, completely stressed out medical resident.
Been there.
You've had way too much coffee, you haven't slept properly in days, and you are sitting in a dead silent room staring at a screen. You're taking the few-mark board exam.
A very specific, and I have to say, notoriously rigorous examination.
Exactly. And you're staring at one single question. Question number 114626. Our mission today isn't just to find the right answer. I mean, that would be too easy, wouldn't it?
A bit anticlimactic.
Right. We are going to use this single question as a launch pad. We're going to use it to completely dismantle and then rebuild our understanding of one of the most complex systemic inflammatory diseases in human history, psoriasis.
It really is a fantastic approach. A well-written board question is like a hologram. If you shine a light on it from just the right angle, it projects the entire universe of the disease.
That's a great way to put it.
It really does. It touches on genetics, the clinical science, pharmacology, and all the deep molecular machinery of the body. It's all packed in there.
So let's set the stage. The prompt is simple, deceptively simple. It reads, year 2006. All questions related to psoriasis are correct, except T.
The classic except question, the negative stem.
The absolute bane of test takers everywhere. Just plays mind games with you, doesn't it? It means that 3 of the options we're about to discuss are absolute medical facts. They are true.
And one of them is an imposter.
One of them is a lie.
And our job is to find the lie. But in doing that, like you said, we're effectively building a complete profile of the disease from the ground up.
Okay, so before we get into the weeds, before we start dissecting every last detail, let's just rip the Band-Aid off. I want to reveal the answer right now, the exception, so we can frame the whole conversation. We'll explain why it's wrong, and then we can spend the rest of our time celebrating the truth of the other options.
Sounds like a solid plan. It clears the air right away.
Okay, so the answer, the incorrect statement in this question from 2006 is option B. Let me read it to you carefully.
Let's hear it.
The histocompatibility antigen HLA-DR4 is frequently seen in patients with psoriatic arthritis, being more frequent than HLA-CW6 in these cases.
And that right there is the lie. That's the imposter.
Okay, let's unpack this. Why is option B the exception? It sounds so technical with all these letters and numbers. HLA-DR4, HLA-CW6. What's going on here?
It is technical, but it's a very clever, nuanced error. It's a trap designed to catch someone who only has a surface-level knowledge. To understand this, we have to talk about the, let's call it the genetic royalty of psoriasis.
Genetic royalty, I like that.
This statement, option B, it tries to claim that HLA-DR4 is the main character in psoriatic arthritis, or at the very least, that it's more important, more frequent than HLA-CW6. But the reality is, HLA-CW6 is the heavyweight champion.
The king.
The king. It is, without a doubt, the strongest single genetic marker associated with psoriasis, period. This applies specifically to the skin manifestations, the classic blacks, but it also holds true for a huge number of the articular cases, the arthritis.
So when the statement says DR4 is more frequent, that's the specific part that's wrong.
That is the dagger. That's the lie. It's a comparative claim that is factually false. Because HLA-DR4 is a very famous marker, don't get me wrong, but it's the villain in a different story.
A different disease.
Exactly. HLA-DR4 is primarily and famously associated with rheumatoid arthritis.
Ah, I see. Okay, so they've swapped the arthritis markers. They're banking on the stressed out resident seeing the word arthritis, and their brain just jumping to the most famous arthritis gene they know.
Precisely. You see arthritis, you panic, you think, oh, arthritis, that must be DR4. But psoriatic arthritis is its own beast with its own genetic signature.
So what about other arthritis markers? Is it just CW6?
Well, it's more complex than that. If we were talking specifically about spondyloarthropathies, that's arthritis that affects the spine, the axial skeleton, we would be talking about a different marker entirely. HLA-B27, that's the classic one for things like ankylosing spondylitis.
So B27 for the spine, DR4 for rheumatoid arthritis.
And for psoriasis, both the skin and often the joints, HLA-CW6 remains the allele of highest risk. It's the dominant genetic driver. So to say DR4 is more frequent is just incorrect.
A very elegant trap. Okay, so we've identified the imposter. Option B is out. The king is CW6, not DR4. Now this brings us perfectly to option A, which, because this is an except question, must be a true statement.
Correct. Since B was the lie, A must be the truth.
Option A says, there is a strong association of early onset psoriasis with class 1 and 2 histocompatibility antigens, including B13, BW57, CW6, and DR7. Now help us understand what this alphabet soup actually means in practice.
This is where we get into a really important clinical distinction.
Yeah.
We have to divide the world of psoriasis into 2 distinct camps. We often think of psoriasis as just one thing. You have a rash, you have psoriasis. But clinically and genetically, we divide it into type I and type 2.
What's the fundamental difference?
It's all about timing and family. Type I is the early onset form. This is the one that strikes young people, usually before the age of 40. The peak incidence is actually between ages 20 and 30.
That's the prime of life. That's brutal.
It is. And type I is the one that is strongly genetic. If you have type I psoriasis, it is almost certain that you have a strong family history of it. Your father had it, your grandmother had it, an uncle had it. It runs in the family. Supporting actors listed right there in option A.
B13, BW57, and DR7.
Yes. They are all part of the genetic profile, the genetic loaded gun for early onset disease.
So if a patient walks into your clinic, they're 25 years old, they have these classic plaques, and they tell you their dad has psoriasis, you're almost certainly looking at type I. And if you could test their blood, you'd expect to find these specific markers.
Precisely. Now contrast that with type 2.
Which I assume is late onset.
Correct. Type 2 usually appears after age 40, with a peak incidence between 50 and 60. And here's the interesting part. This type is generally sporadic.
Meaning no family history.
Very little, usually, and the genetic link. It's much, much weaker. You don't see that strong correlation with HLA-CW6 or the other markers from option A. It seems to be driven by other, perhaps environmental factors later in life.
That is fascinating. So it's the same disease. It looks clinically very similar on the skin, but it can have two completely different backstories depending on when it starts.
Exactly. One is deeply encoded in your lineage, almost like a family inheritance, and the other is more of a sporadic event that happens later in life. And that's what makes option A a perfectly correct and very nuanced statement. It specifically says early onset psoriasis is linked to those antigens. It's an accurate description of type I disease.
I love how this question forces you to know that distinction. It's not enough to just know genes cause psoriasis. You have to know which genes cause which type. It's a higher level of understanding.
It absolutely is.
Okay, let's move from the microscope in the gene lab to the exam room. Let's look at option C.
The clinical signs. This is where it gets visual, gets physical.
Option C reads, Auspit sign has diagnostic value in psoriasis and is not present in inverse psoriasis and pustular psoriasis. Now, since option B was the lie, this must be true, but there is a lot to unpack here. First things first, what on earth is the Auspit sign?
It's one of the most famous eponyms in all of dermatology. It's named after Heinrich Auspitz, a 19th century dermatologist, but it's also sometimes called the sign of the bloody dew, or value sanguíneo in Portuguese.
Bloody dew. That is incredibly vivid. It sounds almost poetic.
It is, and it's very descriptive. To understand it, you have to picture the pathology of a psoriatic plaque. Imagine a classic plaque on someone's elbow. It's thick, it's red, and it's covered in this silvery mica-like scale.
Right.
Now, if you were to perform what dermatologists call the methodical scraping of Brock, which is really just a fancy way of saying you carefully, layer by layer, scratch off the lesion with something like a glass slide.
A curette, maybe?
Yes, a curette works perfectly. You see a very specific sequence of events. It's like a 3-act play on the skin.
Okay, walk us through the scraping. It sounds like an archaeological dig.
It kind of is. So act 1. As you begin to gently scrape, the scales come off in these white, waxy flakes. This is called the sign of the candle stain. It looks exactly like if you scratched a white tallow candle and the wax crumbled off.
Okay, that's step 1. The candle wax comes off.
Act 2. As you keep scraping, the scales are all gone, and you reveal a thin, shiny, coherent film. It looks like a little wet membrane stretched over the red skin. This is called the Duncan-Dulkley membrane. It's the very last layer of the epidermis before you hit the dermis below.
We are going deep into the history of dermatology names here. Brock, Duncan, Dulkley, Auspitz.
We are, but here's the finale, Act 3. If you remove that membrane, if you just gently detach it, something dramatic happens. You suddenly see tiny, pinpoint drops of blood springing up all over the surface. That is the Auspitz sign. The bloody dew. You're like projections of the dermis that push up into the epidermis.
Right, they interlock like puzzle pieces.
Normally they do. In psoriasis, they become incredibly elongated. They're stretched out like these long, thin towers reaching up towards the surface. And inside those papillae, the tiny capillary blood vessels are dilated and tortuous. They're twisted and swollen and sitting right at the top of these towers.
So the blood is sitting just microns below the surface.
Exactly. The plate of skin, the epidermis, over those vessels is paper thin. So when you scrape off the scale in that final membrane, you are essentially decapitating the tops of those tiny dilated capillaries, and hence the bloody dew.
Wow, that makes perfect sense. It's a structural issue, so that's the sign. But the option says it is not present in inverse psoriasis and pustular psoriasis. Why is that true? Why the exceptions?
And this is where the logic of the question comes back in. This is why it's a correct statement. Let's take inverse psoriasis first. This happens in the body folds, the armpits, the groin, under the breasts.
The sweaty areas, basically.
Correct. And because these areas are naturally moist and subject to friction, they're macerated. The typical thick, dry, silvery scaling just doesn't form properly. It's too wet. The lesion is usually just red and shiny, maybe with a scissure. So if you don't have the scale building up, you don't get that specific architecture that leads to the Auspitz. Is a different beast entirely. It's an even more intense form of inflammation. Instead of just having rapidly dividing skin cells, you have a massive influx of neutrophils, those white blood cells, rushing into the epidermis and creating tiny lakes of pustules.
So it's an exudative process. It's wet.
It's very wet. It's inflammatory in a totally different way. It doesn't form that dry perikeratotic scale that you need to scrape to demonstrate the sign. The pathology is just different.
So the rule is, Auspitz is for the classic, dry, scaly, plaque psoriasis vulgaris. If the lesion is wet because it's in a fold, or wet because it's filled with pus, the sign is absent.
That's the rule. And there's actually a mnemonic for this, a little trick to remember it.
Let's hear it.
Just think of the name IUETZ itself. The U can stand for umida, which is Portuguese for moist or humid. This reminds you that in the moist areas of inverse psoriasis, the sign is absent. And the T can stand for typical of the vulgar type. It reminds you that this is a sign for the classic typical plaque psoriasis, not the other variants.
That is incredibly helpful. It really cements the idea that you can't just apply one rule to every single presentation of the disease. You have to know the subtypes.
You really do. Context is everything.
Okay, that was C. Moving on to our last true statement, option D. This one is about pharmacology. What triggers the disease?
Yes, the drug.
CE inhibitors are drugs that can exacerbate psoriasis. And again, since B was the lie, this has to be the truth. These drugs are bad news for psoriasis patients.
They absolutely are. They are some of the most well-known culprits. We actually have a classic acronym to help remember the worst offenders. It's LABI. LABI.
LABI. Okay, break it down for us.
L is for lithium. It's a mood stabilizer, often used for bipolar disorder, but it is a notorious trigger for causing or worsening psoriasis.
Okay.
A is for antimalarials, drugs like chloroquine or hydroxychloroquine. The mechanism is complex, but they seem to interfere with keratinocyte proliferation in a way that can cause a massive flare.
Got it. What about B?
B is for beta blockers. These are super common. Millions of people are on them for high blood pressure or heart conditions. The mechanism here is fascinating. They alter the levels of an intracellular messenger called cyclic AMP or CANMP. This drop in CANMP can, in some people, trigger that rapid cell turnover we see in psoriasis.
And finally, I.
I is for inhibitors of ACE, or ACE inhibitors, another incredibly common class of blood pressure medication. They can exacerbate cutaneous inflammation, we think, by affecting levels of a substance called bradykinin.
So lithium, antimalarials, beta blockers, ACE inhibitors, LABI. It's a pretty critical list to have in your head if you're treating a patient with psoriasis.
It's absolutely essential. But there's one more class of drug that isn't in the acronym, but it acts as a massive trap in exams and, more importantly, in clinical practice. We have to mention it because the consequences of getting this wrong are so severe.
Okay, what is it?
Systemic corticosteroids.
Wait a second. That seems counterintuitive. I thought steroids treated inflammation. If I have a rash, the first thing a doctor gives me is a steroid cream.
And that's the key distinction. Topical is fine. We are talking about systemic pills or injections. Prednisone, for example. Here's the paradox. If you give a psoriasis patient a shot of prednisone or a course of pills, their skin will clear up beautifully. It will look like magic.
So what's the problem? That sounds great.
The problem is when you stop. When the steroids wear off, you get a rebound effect. The disease doesn't just come back. It comes back with a vengeance. It comes back angry. It can transform a stable, manageable plaque psoriasis into generalized pustular psoriasis, also known as the von Zumbusch type.
That sounds terrifying. You mentioned pustular psoriasis earlier.
This is the most severe form. It is a life-threatening medical emergency. The patient becomes erythrodermic, their entire body turns beet red, and they're covered in sheets of tiny pustules. They get high fevers, their electrolytes go haywire. It requires immediate hospitalization and intensive care.
Wow. All from stopping a steroid.
All from the rebound effect. So the golden rule in dermatology, the absolute commandment is never, ever treat routine plaque psoriasis with systemic steroids. You are lighting a fuse on a bomb.
That is a critical takeaway. Okay, so we've validated the options. We've taken this 2006 question apart. We know why B is wrong and why A, C, and D are right. But I want to zoom out a bit now. We keep talking about this rapid turnover and scales and inflammation. What is actually happening in the engine room of the skin? Let's do a real deep dive on the pathophysiology.
Let's do it. To understand psoriasis, you have to understand the speed of skin.
The speed of skin. I like that phrase.
In a normal person, a skin cell, what we call a keratinocyte, is born at the very bottom of the epidermis in the basal layer. It then begins a slow, orderly journey upwards. It matures, it changes shape, it loses its nucleus, it becomes a flat dead cell called a corneocyte, and it gently falls off. That entire journey takes about 28 days.
A nice leisurely month-long vacation from birth to retirement.
Exactly. It's a controlled, elegant process. In psoriasis, that entire system is hijacked. The immune system starts screaming at the skin cells to move faster, to divide and move. That 28-day journey gets compressed into just 3 to 5 days.
3 to 5 days, that's almost 10 times faster.
It's an absolute frenzy. The cells are reproducing frantically, climbing over each other to get to the top, but because they're moving so fast, they don't have time to mature properly. They reach the surface, well, they are still alive in a sense. They still have their nuclei.
Which is not supposed to happen, right? The outer layer should be dead cells.
It's a cardinal sin of skin biology. The stratum corneum, the outer layer, is supposed to be enucleated. It's a wall of dead bricks. When these immature cells with nuclei get there, we call that parakeratosis. This is the microscopic hallmark of psoriasis. And this is why the scales are so flaky and silver. It's just piles and piles of these immature sticky cells that have stacked up because they aren't shedding correctly.
And what's the driver? Who is pressing the gas pedal so hard?
It's the immune system. Specifically, it's a T-cell mediated disease. Think of it as an axis of miscommunication. It starts with cells called dendritic cells in the skin. They get an erroneous signal that there's a problem, and they release a cytokine, a signal molecule called interleukin-23, IL-23.
Okay, so IL-23 is the first domino.
It is. IL-23 then finds a specific type of T cell called a Th17 cell. IL-23 basically tells the Th17 cell to wake up and get to work. The Th17 cell then becomes an inflammation factory, and it starts pumping out massive amounts of another cytokine, IL-17.
So IL-17 is the real culprit here, the one doing the damage.
IL-17 is the commander on the battlefield. It's the one that does two main things. First, it screams at the skin cells to multiply, causing that 3 to 5 day cycle. Second, it acts as a chemical siren, calling in neutrophils, those white blood cells that usually fight bacteria.
And the neutrophils just rush into the skin?
They rush into the epidermis, and they form these tiny microscopic pockets of pus. We call these Monroe's microabscesses.
Monroe's microabscesses, that's another one of those classic board exam buzzwords.
It is. It's what you see under the microscope. So you have this triad: rapid growth of skin cells, acanthosis, incomplete maturation, parakeratosis, and an invasion of neutrophils, Monroe's microabscesses.
And what about the redness, the erythema?
Right. Well, the skin needs food and oxygen to support this crazy tumor-like growth rate, so it triggers angiogenesis.
Blood vessels.
Exactly. The body builds new, twisted, dilated blood vessels to feed the hyperproliferative skin. That's why the plaques are so intensely red. And that brings us full circle. Back to the Auspitz sign. Those are the very vessels that you're nicking when you scrape the plaque.
It's all connected. The genes turn on the T cells release the cytokines cause the rapid growth and call in the neutrophils, the rapid growth requires new blood vessels, and the blood vessels cause the redness and the bleeding sign. It's one big vicious loop.
It really is, a self-sustaining cycle of inflammation.
Okay, so we've covered the why and the how. Let's talk about the what. What does this look like to the patient and the doctor? We mentioned the plaques, but let's get more specific.
We call it the sovereign clinic, meaning the clinical picture is usually so clear that it rules over all other tests. The classic presentation is the erythematous squamous plaque. Red skin, silver scales. A key feature is that they are very well demarcated.
Meaning you can see the edge clearly.
You can trace it with a pen. You can see exactly where the diseased skin starts and the normal skin stops.
And where do we usually find them? What are the classic locations?
The classic spots are the extensor surfaces. The tops of the elbows and the front of the knees are the most common. Also the scalp, which can be mistaken for really bad dandruff, and the sacral region, the lower back, right above the tailbone.
It's interesting that elbows and knees are so common. Those are areas that get a lot of friction and pressure.
And that relates directly to another classic sign, the Koebner phenomenon.
Right, you mentioned this. This is where trauma causes a new lesion.
Precisely. The Koebner phenomenon, or isomorphic response, is where new psoriatic lesions appear at sites of skin trauma. If a patient with active psoriasis gets a simple scratch, a sunburn, or even surgical incision, a new plaque will often form right along that line of injury a week or two later.
Does that happen in any other diseases? Or is it unique to psoriasis?
It's not unique, which is an important point. We see it very clearly in vitiligo, where trauma can cause new white patches and a lichen planus. But it is very, very characteristic of psoriasis. It tells you the entire skin is primed and ready to react.
What about the nails? You said earlier that the nails are a window into the joints. Can you expand on that?
Yes, the nails are incredibly important. About half of patients with psoriasis have nail involvement, and it can be a major clue. We see several classic changes. The most common is pitting.
Pitting?
It looks like someone took a tiny ice pick or a pin and made a bunch of little cup-like depressions in the nail plate. It could be a few pits, or the whole nail can look like a thimble.
And what else?
We also see something called oil drop spots, or salmon patches. This looks exactly like a drop of yellowish-brown oil has been trapped under the nail. It's caused by inflammation in the nail bed underneath. You can also see splinter hemorrhages and even total destruction of the nail plate in severe cases.
And why does this matter so much? Is it just a cosmetic issue?
It matters because nail involvement is one of the strongest predictors we have for the future development of psoriatic arthritis. Up to 80% of people with psoriatic arthritis have nail changes. So if you see a patient with bad psoriatic nails, you need to be actively asking them about joint pain, stiffness, and swelling. It's a huge red flag.
Okay, let's talk treatment. We've established that we can't cure it, at least not yet, but we can control it. How has the approach to treatment evolved over the years?
It has been a complete revolution. We used to rely on, as you said, creams and tar.
Right.
And for mild disease, that's still where we start. This is the first step on the therapeutic ladder.
What's on that first step?
Topical corticosteroids are the workhorse. We also use vitamin D analogs like calcipotriol. They work locally to slow down the cell proliferation and calm the inflammation in the skin. Keratolytics, like salicylic acid, can help break down the thick scale so the other medicines can penetrate better.
What if that's not enough? What's the next step up the ladder?
The next step is usually phototherapy, using light as a medicine.
So
exactly. We use controlled doses of ultraviolet light. The most common is UVB narrowband, or sometimes PUVA, which combines a photosensitizing drug with UVA light. It's a fascinating mechanism. The UV radiation actually penetrates the skin and induces apoptosis-programmed cell death, specifically of those overactive T lymphocytes that are driving the disease.
So you're essentially using sunlight to selectively kill off the rogue immune cells in the skin.
That's a perfect way to describe it. This is why many patients find their psoriasis gets much better in the summer.
And if light therapy doesn't work or isn't practical?
Then we climb to the third step, traditional systemic drugs. These are pills or injections that work throughout the body. The classic ones are methotrexate, acitretin, which is a retinoid, a vitamin A derivative, and cyclosporine.
These are pretty heavy-duty drugs, aren't they?
They are. They are broad immunosuppressants. They dampen the whole immune system, which is effective, but it comes with a higher risk of side effects and requires careful monitoring. But the real game changer has been the top step of the ladder, biologics.
The smart bombs, the targeted therapies.
Yes, this has changed everything. These are laboratory-engineered antibodies. Instead of suppressing the whole immune system like a carpet bomb, they are designed to find and neutralize one specific molecule in that inflammatory cascade we talked about.
So they can target TNF or IL-17 or IL-23 directly?
Precisely. We have anti-TNF drugs, anti-IL-17 drugs, and anti-IL-23 drugs.
Right.
We can stop the signal right at the source. The results can be life-changing. We're now seeing a majority of patients on these drugs achieving PSI 90 or even PSI 100.
What does that mean, PSI 90?
PSI is the psoriasis area and severity index. It's a score of how bad the disease is. PSI 90 means a 90% improvement, a 90% clearance of skin lesions. PSI 100 means completely clear skin. That was almost unheard of 20 years ago when this exam question was written.
That is absolutely amazing. It's true precision medicine in action. Now, speaking of nature and biology, I want to take a weird turn, if you don't mind.
I love a weird turn. Let's do it.
Our research notes for this dive have a section called Secrets of the Animal Kingdom. It draws these incredible analogies between psoriasis and different animals.
Oh, this is great. I love this stuff. It really helps visualize the pathology in a different way.
Let's start with the snake, the serpentes.
Okay, the snake. Think about a snake shedding its skin. It's a process called eketasis. The snake sheds its entire outer layer of skin in one single, graceful, complete piece. It's a perfect, controlled cycle of renewal.
Right. It's very clean.
Psoriasis is like a desperate failed attempt at that. The human skin is trying to shed every 3 to 5 days instead of every 28. It's trying to do a rapid-fire ectasis, but it fails spectacularly. The cells can't detach properly, so instead of a graceful shedding, the skin just piles up. Those silver scales are just the wreckage of a failed, messy snake skin.
That is a hauntingly beautiful image. What about the alligator, the Cayman laterostris?
The alligator. Alligators and crocodiles have something called osteoderms, actual plates of bone embedded in their skin for protection. It's literal armor. In chronic, long-standing psoriasis, the skin can become lichenified. It gets incredibly thick, hard, and leathery from all the inflammation and scratching. It looks and feels like alligator armor. But unlike the alligator, where the armor is protective, in humans, it's pathological. It cracks, it bleeds, it's intensely itchy and painful. It's armor that hurts you.
It's a protective mechanism gone haywire. Okay, and finally, the chameleon.
The chameleon is all about color change, right? It uses specialized cells called chromatophores to adapt to its environment. Psoriasis also involves a dramatic color change, but it's not for camouflage. It's about blood.
The erythema, the redness.
The intense erythema from all that vasodilation. But think about what happens if this goes body-wide in a condition called erythroderma. The entire skin is bright red. The human in that state is like a reptile that can't control its temperature. You lose heat and fluid through the skin at a massive rate. You can become hypothermic and dehydrated. It shows how the skin is this crucial organ of homeostasis and how psoriasis can completely break that balance.
Man, biology is just wild. It's like the disease is borrowing these extreme, powerful mechanisms from the animal kingdom, but using them in a chaotic, destructive way inside the human body.
It really is. It puts the human pathology into a much broader biological context, doesn't it?
It does. And speaking of broad context, I want to touch on the Nobel-worthy connections here. We talked about biologics, but the science that made those drugs possible goes back to some real heavy hitters in science.
Absolutely. You can literally trace our modern understanding of psoriasis through a series of Nobel Prizes. You go way back to 1905. You have Robert Koch.
The tuberculosis guy.
Right, he won for tuberculosis.
Yeah.
But his work on the tuberculin reaction essentially defined the concept of cellular immunity and delayed type hypersensitivity. That laid the conceptual groundwork for understanding that our own T cells could be responsible for attacking our own tissues.
So he planted the seed. Who came next?
Fast forward a century. In 2011, Butler and Hoffman won the Nobel Prize for their discovery of toll-like receptors. These are the sensors of our innate immune system. They're like the tripwires.
And how does that connect to psoriasis?
We now know that in psoriasis, the patient's own DNA, released from damaged skin cells, can get bundled with a protein called LL37. This complex then activates these toll-like receptors on dendritic cells. It's the trigger. It's what flips the on switch for the whole inflammatory cascade.
So they discovered the ignition system for the disease.
A huge part of it, yes. And then you have the most recent prize, Allison and Hanjo in 2018. They won for their work on checkpoint inhibitors in cancer therapy. But their fundamental discovery was about understanding how to break or accelerate the immune system. That entire field of knowledge paved the way for developing biologic drugs that can specifically block one of those accelerator molecules, like IL-23 or IL-17, and stop the psoriatic cascade in its tracks.
It really makes you realize we're standing on the shoulders of giants.
It puts the practice of medicine into perspective. You're not just prescribing a drug, you're applying a century of Nobel-winning science to help a patient.
It adds a little gravity to the prescription pad, doesn't it?
It certainly does.
Before we wrap up, I think it's important to touch on the human side of this. The history and the stigma associated with such a visible disease.
Yes, that's crucial. The word psoriasis itself comes from the Greek word psora, which means to itch. Although, for many patients, the scaling and soreness are actually more prominent than the itch.
And historically, getting this diagnosis was a rough deal.
It was devastating. In ancient times, and even up through medieval times, any chronic scaly skin disease was often feared. Psoriasis was frequently confused with leprosy, what we now call Hansen's disease.
Which was seen as a curse.
Exactly. People were treated as unclean,
Yeah.
They were isolated from their communities, shunned, sometimes forced to live in leper colonies or ring bells to warn others of their approach. The social and psychological stigma was immense.
And even today, when we know it's not contagious, that stigma lingers, doesn't it? People stare, they ask insensitive questions.
They do. It's a very visible disease. It can have a profound impact on self-esteem, on relationships, on mental health. There's a very high rate of depression and anxiety in patients with moderate to severe psoriasis.
There's a very famous historical case, Winston Churchill.
Yes, a perfect example. Winston Churchill, one of the most powerful and resilient figures of the 20th century, suffered from severe psoriasis his whole adult life. He was dealing with a world war, but he was helpless against his own skin.
And he had a famous quote about her.
He did. He reportedly said he would give half his kingdom to anyone who could find a cure for his scourge.
Half his kingdom. If that doesn't tell you the burden of this disease, nothing will.
It really says it all.
Okay, we have traveled from a 2006 board exam to ancient Greece, from the gene lab to the alligator swamp. Let's bring it all home. Let's do a quick recap.
All right, we solved the question. We identified option B as the lie because HLA-CW6 is the undisputed king of psoriasis genetics, not HLA-DR4.
We learned the ALABI drugs to avoid.
Lithium, antimalarials, beta blockers, ACE inhibitors. And we learned the most important lesson. Never, ever use systemic steroids for routine psoriasis.
We visualized the Auspitz sign, the bloody dew, and that frantic 3 to 5 day life cycle of a psoriatic skin cell.
And we connected all of that to the deeper immune system symphony, conducted by molecules like IL-23 and IL-17.
So after all that, what is the final provocative thought for our listener? What should they be mulling over as we sign off?
I think it's this. Psoriasis is not just skin deep. That is the biggest misconception. It is a systemic inflammatory state. There's a concept now called the psoriatic march.
The psoriatic march.
Yes, we know that having this level of chronic simmering inflammation throughout your body significantly increases your risk of other serious conditions. Metabolic syndrome, diabetes, and especially cardiovascular disease, heart attacks, and strokes. The skin is just the window. It's the most visible sign of an immune system in overdraft.
So treating the skin isn't just about clearing up a rash. It's about treating the whole body and potentially preventing a heart attack down the line.
That is exactly it. And the most hopeful part of this whole story is how far we've come. We've moved from using crude creams and tar, which was the best we had for centuries, to targeting specific molecules with an incredible degree of precision. It's a journey that has fundamentally changed the lives of millions of people, like Churchill, who once would have given up a kingdom for a cure.
That is a great place to end. Thanks for diving deep with us. We'll catch you on the next exploration.
Stay curious, everyone.